All right, Drew, you're good to go.
All right, appreciate it. For those who don't know me, my name is Drew Ward. I am one of the pharmacists here at WVU Medicine, WVU Hospitals at Ruby here in Morgantown, West Virginia. I'm an infectious diseases clinical pharmacist, so I have experience working alongside our physicians who will be presenting cases today, as well as being involved in our local antimicrobial stewardship efforts. Today, I was going to provide a very brief presentation on something that I think has some clinical controversy surrounding it, especially in different indications as it relates to pulmonary infections. And that's related to daptomycin and its use in pulmonary infections. So our objective today, after this brief presentation, will be to recall pearls of daptomycin use in pulmonary infections. As a brief refresher, daptomycin is a very convenient once daily IV antimicrobial. It has activity against a wide array of gram-positive organisms, including methicillin-resistant Staph aureus or MRSA, or bank-resistant enterococci, also known as VRE. For the latter, we often evaluate the MIC reported to the VRE isolate before determining whether daptomycin is an appropriate therapy or not, but it often is a tool within our belt when it comes to that organism and associated infections. Briefly reviewing its mechanism of action. So this is a calcium-dependent mechanism of action by which daptomycin inserts itself into the lipophilic membrane layer of gram-positive cells, ultimately promoting the opening of those cell membranes, the rushing out of potassium ions causing depolarization, membrane instability, and ultimately death of a bacterial cell. The reason this is important in the case of pulmonary infections predominantly has to do with its use in cases of pneumonia. So pulmonary surfactant, which is found lining the alveolar spaces within the lungs, has the ability to inactivate daptomycin. This is essentially done because the surfactant micelles very similarly resemble those that you may find on a bacterial cell wall or cell membrane. So in a way, it kind of tricks daptomycin into thinking it's attacking a bacterial cell or a phospholipid layer in a bacterial cell membrane. And thus the daptomycin within the lung space, the parenchymal alveolar space, isn't able to act on bacteria in the region. This was first robustly described in 2005. Initially, studies that looked at daptomycin, especially in animal models, even looked at its use in pneumonia. But subsequent failures attributed to daptomycin treatment with pneumonia led to the discovery that surfactant inactivates its use. So there's kind of three takeaways that I'm hoping to convey through this presentation today, but the very first and maybe most important one is in true cases of bacterial pneumonia in which the alveolar space is involved, the cause of pulmonary surfactant, daptomycin is not an option for treatment and has been associated with treatment failure. Next, I wanted to propose a slightly different clinical scenario, and this is the case of pleural empyema, so infection of the pleural space, the space between the lungs and the chest wall. I pulled a case report from 2022 that was written by Torjani and colleagues that described a 26-year-old male that initially was treated with vancomycin and then linezolid upon isolating VRE from the pleural space, who subsequently failed treatment with linezolid, and thus the investigators then turned to IV daptomycin as an option for treatment of this empyema. He was successfully treated after several weeks of therapy. Duration of therapy for empyema can vary, often depending on a patient's clinical response, anywhere from the 2 to 6 week range based on thoracic surgery guidelines. Importantly, in the case of Torjani, there was no concomitant untreated pneumonia. So the authors make it very clear that this would probably have not been as acceptable of a treatment option had the patient had an underlying pneumonia associated with the empyema, which often can be the case in those types of infections. In addition to this, I looked at 2 other case reports in which patients with either VRE or MRSA empyema were treated with daptomycin successfully. And so kind of takeaways from this and what other literature is available out there is that daptomycin for empyema or infection of a pleural effusion, alternatively, could be an option to IV vancomycin. If you did some further digging, there's actually some literature out there to suggest that antibiotics other than vancomycin, like linezolid and like daptomycin, may even be slightly superior than IV vancomycin in the treatment of these infections. Daptomycin in the case of empyema shouldn't be used alone if concomitant pneumonia is present. And interesting enough, there is a type of surfactant that does exist within the pleural space, but its lipid makeup differs quite significantly from that of parenchymal surfactant that's found in the alveolar space. And thus, daptomycin isn't as readily neutralized whenever it enters that particular part of the body. And so for this indication, I gave a big smiley face with an asterisk for the treatment of empyema with daptomycin, with the asterisk being if there's concomitant pneumonia that's expected to be active or going on, an additional agent or an alternative agent would need to be considered when using daptomycin in this indication. The last clinical scenario I was going to briefly mention was that of pulmonary septic emboli, often as a result of endocarditis, frequently of the right side of the heart, when part of the embolus or part of the vegetation that may form on the valve on the right side of the heart may break off and find itself into the lung space and the lung vasculature specifically and cause these emboli to show on imaging, in this case, a CT scan cross-section that I provided here. I don't think I would have time to summarize all of the case reports and small trial data that's out there for the case of treating infective endocarditis and pulmonary septic emboli with daptomycin. But I will point to this 2019 review by Crass and colleagues that essentially summarized clinical experience with daptomycin, infective endocarditis, and pulmonary septic emboli has been mixed. Now, the reason why this could be the case, so when we think of emboli lodging itself in the pulmonary vasculature, typically we wouldn't think of that invading the alveolar space where pulmonary surfactant would deactivate daptomycin. And so there is some belief, and some practitioners hold the belief that daptomycin is an acceptable treatment option whenever patients have this complication of infective endocarditis. The largest scale study, if you will, of patients that were treated with daptomycin and had concomitant pulmonary septic emboli was completed by Fowler and colleagues in 2006. They include a total of 19 patients with a complication of pulmonary septic emboli. And of those, in a post hoc analysis conducted a few years later, about 50 to 60% of those patients underwent successful treatment of daptomycin, of their infection with daptomycin, which was relatively similar to that of the comparative group in this trial, which was IV vancomycin. But of note, these are obviously very small numbers. And subsequent case reports, whether in cases of endocarditis or other bacterial pulmonary septic emboli, have been more mixed. And so I summarize this with a question mark in that it really kind of depends On a patient-to-patient basis, it seems, as to whether patients improve on this regimen. In theory, I think the logic makes sense to be able to use daptomycin if there's not inherent infection within the alveolar space, the lung parenchyma. You should be able to target emboli within the lungs because it's relegated to the vasculature, and daptomycin shouldn't have issues concentrating there. And so I had, after that, I wanted to kind of quickly just poll the audience. In the case of pneumonia, can daptomycin be reused because of its reliable activity against gram-positive organisms that could cause this infection? Is that statement true or false? You're welcome to use the chat feature, unmute, however you like.
Does anybody want to take a wild guess?
Okay, so if you'll remember from a couple slides ago, if we're treating a pneumonia involving the alveolar space as a traditional pneumonia would, daptomycin would not be appropriate. Even though it does have activity against gram-positive organisms that may cause this infection, such as Staphylococcus aureus or a few different strep species. Because of that inactivation, it's often associated with treatment failure in cases of pneumonia. And then really the last thing I wanted to do was hopefully encourage some audience participation and discussion is kind of just gauge how the group feels on a comfortability level using daptomycin in these 3 different cases. If there's anyone that wanted to briefly share an experience, either positive or negative as it relates to a couple of these cases or these infection types. So I was going to open the floor up briefly for that, but otherwise that's all I have for today. So happy to hear what you all think about daptomycin's use in the couple of indications I've discussed today.
Thank you, Drew. Does anybody want to add in to the discussion?
I would say, so from a pulmonary empyema standpoint, one of the things that would be really helpful to kind of know is like, how did that patient get that empyema? So the one you presented with the VRE and the young patient, I wonder if that was something like intra-abdominal that then came up, which to me is, didn't go into the respiratory system and then out. So that would make me more comfortable with daptomycin and just knowing then that we're really like outside of the issues with surfactant.
That's a good point, Dr. Johnson. So that particular case was a 26-year-old with an IVDU history. So it's believed that was somehow related to how he initially acquired the infection. It wasn't an observed pneumonia, like I kind of had mentioned earlier. So the source may have been either from the bloodstream or not initially from the lungs. It seemed to be in the case that I presented.
I would say from the septic emboli standpoint, and I'm not saying that this is correct. A lot of times if the image is just commenting on septic emboli and not like an abscess, I usually feel comfortable with daptomycin, or try and at least push for daptomycin, or feel comfortable if they are on vanc switching to daptomycin, if we need to. But is that kind of, yeah.
I would echo that. I think my own comfort level with septic pulmonary emboli with MRSA bacteremia in particular from endocarditis is high. I think it's a better option. I don't like vancomycin's, levels in the lungs as much at all in terms of and then I think some of the data is suggesting that dapto may be a slightly better endocarditis antibiotic than vanc. needs to be kept in mind. So much more comfortable with the septic PE.
So, well, I
All right,
appreciate
thank you.
your all's contributions and thoughts. My references for you all to take a look at briefly what we discussed today. I'm happy to answer any questions that you might have about what we talked about now or in an email afterwards, but I do once again appreciate this group's time allowing me to present.
Thank you so much, Drew. All right, guys, we are now going to go ahead and move on to our cases.